To the most respected chairpersons, colleagues, and my dear friends, there has been allotted a most important topic, which is the key to success of refractive surgery and optical outcome. That is planning for a refractive surgery, then what workup of the patient should be done. The goal of every refractive surgery is to reduce the dependence on glasses and contact lenses, as we all know, and for which there are a variety of surgical techniques and technologies are available. All of them require an appropriate pre-operative evaluation to determine the best technique and ensure the best optical outcome. So now coming to the patient evaluation. Before touching the patient, one should know the patient, whether he is having an unreasonably high expectation, is a type A personality or not, whether he is self-motivated for refractive surgery or are you forcing upon him. So these patients will not be a good candidate for refractive surgery. Also take a good social and professional history of the patient, as we know that now because of the COVID era, all the youngsters are having a lot of hours for screen time. They are using 8 to 10 hours per day. Then coming to the ocular history, use of contact lenses, any allergy or atopy, history of ocular trauma, any previous systemic or ocular surgeries, any treatment for dry eyes, patient is taking, keratoconus, any history of treatment with collagen cross-linking or any other treatment or diagnosed previously as keratoconus, these all should be very well taken in the history. Recurrent corneal erosions, whether the patient had history of constant rubbing or chronic infections of the eye. Now coming to the refractive history, which would ask about the onset of the refractive errors, is how long he is using the glasses, whether they are stable from past year or so, or is there any history of anisometropia? What is the patient age, whether he is into a presbyopic age or a young patient? Another important aspect is contact lens history. What type of contact lenses patient is using, whether he is using them how many hours a day, what cleaning solutions and practices does he do for cleaning them. So at least for soft contact lenses, they should be stopped 10 to 15 days prior to the surgery, and for rigid lenses, it should be 3 to 4 weeks, because they can, if not, they can alter the topographic features, they can change the amount, type, and axis of astigmatism. Sometimes they can also alter the corneal thickness. Then coming to the general history, diabetes, hypertension, history of allergy, atopy, collagen vascular diseases, pregnancy, lactation, because all these points, they can change the corneal epithelial healing and they can cause problems later on. The optical outcome will not be as expected. Now coming to the actual examination, this slide shows you what array of examination you should do, like visual acuity, uncorrected and best corrected. You should see for the refractive stability of the patient, ocular dominance, contrast sensitivity, cycloplegic and manifest refractions, corneal thickness, corneal imaging, wavefront testing, pupillometry, tear film test, tonometry. If you are going for a phakic IOLs and lens-based surgery, then optical biometry, white-to-white diameter, echo step. Then comes the detailed external and slit lamp examination and a very well indirect ophthalmoscopic any peripheral retinal degenerations. We should look for the stability of the tear film, tear protection, and the ocular surface examination, any Newman gland disease or history of or any chronic irritation or some infections in the eye. As such, there is no universally accepted definition for refractive stability. However, most clinical trials have defined stability as no more than 0.5 diopter change in either sphere or cylinder over a period of 12 months. So this is how we calculate or see the refractive stability. Then another very important part of examination is corneal pachymetry. So this will give you eligibility of the refractive surgery. You can choose the type of refractive surgery you have to perform. Sometimes you can also monitor the flap thickness intraoperatively. You can check for the corneal pathology such as keratoconus or pellucid marginal degenerations. Best way for corneal pachymetry is by tomography, that is imaging by either OCT or pentacam, because ultrasound can give you false results or some changes in the not the correct pachymetry. OCT or pentacam are very good for this. They are non-invasive. Typically, as we know that average is 540 plus minus 30 microns, normal range is 480 to 600 microns. As I told you previously, it is very important in deciding the refractive procedure. Also, we can decide the flap thickness. We are doing, we are using microkeratome or a femto. We can decide the flap thickness depending on the pachymetry. There are different school of thought for residual stromal bed, but normally 250 to 300 microns is the common consensus. And also by pachymetry, we can understand the issues of ablation diameter and the depth. Corneal imaging, I will not go in the detail because Dr. Pankaj Sharma in previous session we have discussed in detail, but mainly there are topography and tomography. Tomography is much better because it gives more maps and profiles, gives the idea of both the corneal surfaces and gives the pachymetric maps. It is the most important tool in screening for refractive surgery because it can detect minor abnormalities, can diagnose amorphostic keratoconus, early ectasias, can classify these ectasias also, and it can diagnose post-keratorefractive ectasias and put the plan for choice in surgery. Also, very importantly, it can diagnose the contact lens warpage. These are the various pentacam pictures that will not go in the detail of this because we have already in the previous session we have discussed about all these things. These are the various irregularities of cornea. So the pentacam, as discussed in the previous section, pentacam is the most important tool for planning of refractive surgery. We had variety of indices in this. ABERROMETRY is another important tool. Can measure the lower order and higher order aberrations. Also, it can be used in calculating custom-based aberration to enhance the vision, or it is important when we are going for retreatments. So the types of refractive surgery today performed, they are either can be cornea-based or lens-based or intraocular. So in cornea-based, we have PRK, LASIK, frontal LASIK, refractive lenticular smile. Intraocular, we have phakic and pseudophakic surgeries. To conclude, the main thing is the psychological assessment of the patient, detailed history, very importantly, meticulous preoperative examination in terms of quality of vision, refractive stability, pachymetry, topography, wavefront testing, pupillometry. So all these things can decide the choice of procedure, and we should individualize every patient so that we get excellent refractive results. Patient satisfaction will be great and surgeon will be in the peace of mind.